Thank you so much, sir. I am following one of the pioneers of hip preservation and probably a very difficult thing. I'm really thankful to sir because he's like I said, the pioneer of hip preservation right now. And I feel that COVID has given us put another focus on a relatively rare disease of avascular necrosis. And like Dr. Agrawal said, that this is the bone problem that is going to be in focus because of the sheer number of cases that have been treated with steroids in India and all over the world. So the disease burden of hip preservation is a post-COVID necessity. And why is it necessity? Because more than 70% of the diagnosed cases of osteonecrosis of the femoral head would require a prosthetic treatment, joint replacement within 3 to 4 years of diagnosis. This is a statistical thing. Most of these are of very young age, with around 70 to 75% being bilateral. And especially in India, where dysplastic hips are not very common, hip arthritis, the major cause of total hip replacement in India is osteonecrosis. So this is a problem which is going to emerge over the next few years. Now, I feel that I want to build a very convincing case for use of these cultured osteoblasts. And I would like to propose these following points to convince you of using or looking at it my way. First is that I would say that this disease per se is not actually avascular necrosis. The International Association for Study of Osteonecrosis has said that it should be called as a osteonecrosis because there is no vascular etiology for osteonecrosis. Though the etiology is not known, there is no particularly vascular etiology. Second thing is that I look at core decompression as a palliative surgery, as not a curative surgery, because definitely in some people it would give a good amount of pain relief, but it may not cure the disease. Third is that I want all of you to look at osteonecrosis uh, staging as well as grading in two different ways because it is very important about when you talk to the patient about the prognosis. I would also will present to you the recent scientific evidence of osteoblast versus BMAC and core decompression. And finally, I will present the results of our studies as well as other investigator studies of these cultured osteoblasts in Indian perspective. Now, first is that osteonecrosis is not avascular necrosis, and it is thought to be because of a programmed cell death or apoptosis. There are multiple studies on this, but like I said, it is thought of to be like a this is thought out to be like a apoptosis. Now, whenever you give a prognosis of any disease, like a cancer surgeon gives a prognosis, we need to know two things. What is the stage of the disease and what is the grade of the disease? For example, a cancer surgeon will talk about whenever he's talking about a malignant tumor, he will talk about a grade of the tumor. That is, how bad is the virulence of the tumor, the mitotic activity of the disease. Also, he will talk about the stage of the disease, whether it is local, regional, or metastatic. I think we need to change our classification or the way that we think to include both these factors, stage as well as grade, before giving any prognosis of the AVN of the patient that we are treating. So what do? We use two classifications as it is, they are very good. First is we stage the disease by the Ficat and Arlet classification, which has been elaborated by Dr. Agarwal. And second is that we need to grade the disease by the ARCO classification. Now, what is the difference in between the two? Staging of the disease means the stage at which we are looking at the disease, whether it is stage 1, stage 2, stage 3, or stage 4. At a rough stage, it helps to for us to make the treatment very clear. So, for example, if it's a stage 1, 2, 3 disease, then probably we can suggest a hip preservation technique. On the other hand, if it is stage 4 disease, then directly the total hip replacement can be suggested. Second important thing is grading of osteonecrosis. Now, when we grade a disease, what it means is that we are looking at the virulence of the disease. So, how do you know the virulence of the disease? How can you, if somebody with a stage 1 disease or a stage 2 disease comes to you, how can you predict that this disease is a virulent disease which is not going to get better with a co-decompression? Okay, so there are good factors which help us do it, and that is there in the ARCO classification. Though they have not named it as grading of AVN, but because these are prognostic signs that we can pick up on MRI and X-ray, I think this can be considered as a grading of AVN. So even if we are looking at a stage 1 or a stage 2 Ficket and Arley, but with a very high grade disease, then the fate of the head is sealed. It would require a hip replacement without intervention. So what are the things that we look at? We look at the size of involvement. I think 30% is the size. Beyond 30%, it is a very high grade disease. The involvement of the crescent, whether you are doing it on X-ray, whether you are doing it or by Kerbol's angle, whether you are doing by volume method of MRI, but the involvement, percentage involvement of the femoral head. Third is the surface collapse or dome depression. I think 2 millimeter or less surface collapse is still okay with hip preservation technique. Beyond 2 millimeter, I think the hip fate is sealed. And finally, the location of whether the medial pillar is involved, the central pillar is involved, or the lateral pillar is involved. All these, if especially the central or the lateral pillar involvement, poses a very high risk of collapse. So therefore, like I said, even if you are looking at a stage 1 Ficat and Arley, if it is a very high disease, it has got a 80% chance of progression to a femoral head collapse within 2 years, irrespective of some treatment like a core decompression. So what are the head at risk sign where I feel that only core decompression may not work? For example, more than 30% of the femoral head involvement of the lateral and the central pillar, Kerbal angle more than 240 degrees, more than 2 millimeter depression in the weight bearing zone, and more than 30% involvement of articular cartilage. Now, these are very logical things which you look at when you are looking at an MRI or a X-ray of a patient. And if you see these signs, then you know that this is something which is beyond core decompression, even though the X-ray facing you at that moment is looking like a stage 1 disease. But if you see any of these signs, then this is a very high grade AVN that you are facing with, and that AVN has got a very high chance of collapsing within 2 years if not offered any treatment. Now, like I said, there are enough papers about core decompression, and after going through a lot of them, I feel that right now core decompression is a palliative surgery, especially it is done when there is less than 30% involvement of the femoral head, the central pillar or the medial side pillar of the femoral head is involved, and it gives excellent pain relief. But when the lateral pillar is involved, I don't think it has got any role in prognostication of the disease. Now, Huijan in 2016, he had a very large study where basically he studied all the various treatments of for AVN. He included everything, and the main disadvantage of core decompression he found, whether you do it with a large drill or a small drill, is only basically a 14% success rate in stage 2, and it causes lower mechanical strain, which causes early failure of the femoral head. Then the next thing that I need to talk about is cell therapy. Now, cell therapy is at an earlier stage. At this 2016, also there is not many articles published for osteoblastic therapy. So when these articles are talking about cell therapy, they are basically talking about injecting bone marrow as well as injecting BMAC or bone marrow aspiration and concentration technique. However, these are the various studies where people have studied after injecting either of these two things, and they found that compared to the other studies, they found that the progression of femoral head to collapse stage were decreased by less than 5 times in the people injected with a cell therapy. Okay, and the chances of having a THR were nearly 50% in the cell therapy group. Now I come to why I believe that the osteoblasts are the future. Now this is a very instructive X-ray, and since I have been doing this treatment for the last 10 years plus, or nearly 10 years now, this X-ray was sent to be my patient who had undergone cell therapy somewhere in India, and he was having some doubts about the cell therapy, so he wanted my opinion, and I consulted him on online, and he sent me the X-ray for review. Now this X-ray is something I found on this X-ray which is really unique. This is basically, you can see the two places. You can see that there is a extra osseous bone formation because of spillover of the cells during the osteoblast implantation surgery. You can see it in both the hips, where some amount of cells may have spilled over into the soft tissue. And lo and behold, you have evidence that the osteoblasts work. And why do they work? Because they are the only bone forming cells in the body. There is no other cell which will form bone in the body other than osteoblasts. Now, not only are the osteoblasts bone forming cells, but they are the cell responsible for new osteogenesis. That is, they recruit other cells around them, that is osteocytes, by secretion of by cytokines to change into osteoblasts. So it's a ongoing process which happens in bone healing, and we can kickstart the similar process in avascular necrosis when these osteoblasts are placed in the right environment. So this is a very instructive X-ray for me, at least. So we come to the procedure now, which is the autologous osteoblastic implantation. As you know that our Regrow, which is an Indian company, was responsible for this pioneering effort, whereby we are able to grow the bone into a petri dish. Now what they do is basically at the first stage, they extract the bone marrow cells. These cells are then transported to the lab in a special apparatus. Then at the lab, they begin the isolation and culture of osteoblastic cells. These cultures are then they are expanded, so they become nearly 50 million osteoblastic cells within a period of 4 to 5 weeks. And these osteoblastic cells, after undergoing quality control, they are then injected into the femoral head to give us the final treatment. So what is it that we do during this surgery? That is, the mesenchymal stem cells are harvested, converted into osteoblasts, and it is used as a cell surface to repair the
Charlie, screen is frozen, I think. Charles, can you unmute yourself?
Yeah.
Yeah, probably you can rejoin again.
Yes, I think he's lost. Yeah.
Disconnected. Yeah. Okay. That was a
Yeah,
wonderful talk.
disconnected.
So,
I'll inform.
yeah, can you just ring him? If he is not going to come back, we will
Yeah.
go ahead with the second one. Yeah. Any questions? I can't see any questions in the chat box, but I think we can have more questions while waiting. And Dr. Babulkar, is there any age restriction, age limit, upper age, where you won't do hip preservation?
More than 50.
More than 50. But now we say up to 60 is young people. We lost you.
Doctor.
I think
probably
can,
I think internet problem. Yeah.
I know.
I will just start my screen share again.
Where people, what happens if I say somebody 50, 55, 56, if I tell him that you're old, they'll get very upset.
Okay.
Yeah.
Can you hear me?
Yeah, we can.
Yes, yes,
Okay.
yes.
So second is core decompression is done with forage, and that is basically to prepare a suitable ground or a medium for laying down the cells. And finally, a gel-based delivery system is used so that there is no loss of cells, which ensures a proper adhesion to the substrate. The main advantage of this system is that we are able to inject a certain number of cells uh, into the femoral head. Now I'm going to show you a few studies. As all of us are aware that one of the biggest names of BMAC and bone marrow was started by these two names, that is Hosier and Gangji. And surprisingly, in 2018, 2016, they came up with a paper which they compared the use of BMAC versus osteoblastic cell. They have these cells which are known as pre-op, and it is right now in a stage 2 clinical protocol, and they may be releasing it in Europe very soon as they finish the stage 2. Now, what they found was that there is, compared to a BMAC or a bone marrow implant, the osteoblastic cell has got a much better result. However, the number of these cells that they are injecting is around 18 million cells, while in India we are getting nearly 48 million cells. So they found that the people with a bone marrow implant, around 40 to 47% of the people progress to a higher stage, while they progressed around only 20% people they progressed to a higher stage when injected with osteoblastic cell implant. Now, like I said, they are using a fewer amount of osteoblastic cells, so we need to take that into consideration as well. These responders had definitely much better pain relief, and functional activity was also much better as compared to the BMAC. Now, for as a part of our regulatory control, we had to, before Osgro was released to the public, we had to undergo a phase 3 clinical trial in India, where this was again a multicentric year, where we studied these patients in around 4 centers all across India, and we had an excellent outcome and safety with the use of osteoblast in India. This is my own paper that I published in Orthopedics in 2021, where I have, these are my earliest patients which were operated in 2010 and 2012, and now they are around 10 or 11 years post surgery. But the data that I had available was at that time around 7 years only. So I had operated on 15 patients and 24 hips. These were all early stage 2A and stage 2B patients. And within 9 months of implantation of these A, all the patients had resumed their normal activity. There was a significant reduction in the Harris hip score. The Harris hip score had increased, the VAS score had reduced, and the Oxford hip score was also better. They were able to walk independently. None of these patients have undergone a hip replacement, and nor has there been any progression of the hip disease. Their hip joints were preserved structurally, and the joint mechanics, strength, and function were retained at the follow-up of 7 years. Again, there was another Indian study, which was a multicentric study in a fairly large subgroup of people of around 101 hips. The average duration of this post-op was around 7.4 years. These was done in stage 2 to stage 4 hips. In spite of there being a stage 2 to stage 4, all of them had a better Harris hip score post-surgery. Around in 3 and 4 hips, around 40% of the hips had undergone total hip replacement, but these were, you can be considered that as 60% did not undergo total hip replacement. But again, the instructive part was that in grade 2A and grade 2B hips, the pain relief was significant, the function improvement was significant, and they did not require any further procedures. So I feel it again that it's a very good procedure for 2A and 2B hips. Now, as with any procedure, there are contraindications to this procedure. And what are the absolute contraindications? Like I said, 3-4 osteonecrosis. Straight away, I would say total hip replacement is the only salvage. Second is there is a significant change in sphericity of the femoral head. So when you are looking at the femoral head and it does not look spherical, though there may be not any obvious collapse, but the head is not spherical, I think the THR makes more sense. In grade 2B hips, where more than 2 mm depression is there, again, it's a very high chance that the patient may not benefit. Uh, AVN associated with renal transplants, because these renal transplant patients, they are on cytotoxic drugs forever for the rest of their lives. If we are implanting cells in them, we do not know the fate of these cells. So that is, I feel, a contraindication. AVN with severe sickling disease. Now, two of my patients I have where there was a severe sickling disease and they have undergone bone marrow transplantation. So I feel that after that, I think it's a very valid indication for doing this procedure. And nowadays, what I've come to in COVID, you should have a look at the amount of femoral head involvement, because I've come across a few patients who are post-COVID where there is a complete femoral head necrosis. Complete femoral head necrosis is, I think, more than 90% of the femoral head is involved. It is really surprising part of the disease, but I don't know whether we should do, because there is no way in which you'll be implanting these cells into a dead zone. So again, I don't know whether it would work or not. So I feel that that would be a uh, contraindication. Another contraindication is, I want you to recognize this MRI, where there is a delamination of cartilage on MRI. So this is a patient where I had, you can see that this is the MRI of the patient. This is a white line where you can make out the delamination, and during total hip replacement, it was confirmed. Uh, Sorry. Second is that this is another patient post-COVID where more than 90% femoral head involvement, and it is completely, the whole femoral head is necrotic. Again, I have done a total hip replacement in this, though there is a relatively spherical head. But as you can see, with this much amount of necrosis, if I am going to inject cells inside this area, then I don't know the fate of the cells. Finally, again, a relative contraindication is AVN with femoroacetabular impingement. As you can see, this patient has got a significant FAI. So even though the head remains spherical throughout for 10 years, the patient, because of FAI, will have a restricted range of motion of the head. So if the patient is willing to understand this part, then he can undergo a hip preservation procedure. Now, what are the relative contraindications? Basically, AVN on low steroids. For example, glomerulonephritis. I have operated on quite a few patients where the patient is on very low growth steroids, something like 2.5 milligrams of isolone, and that is being taperingly and reduced. I think it is a fairly decent way of operating. Inflammatory joint disease. So, for example, if the inflammatory joint disease is very severe, total hip replacement makes sense. But if it has not affected the joint in ankylosing spondylitis or RA, I think and you feel that the patient has got a fairly good amount of cartilage remaining, I think, yeah, the patient can undergo this procedure. Significant FAI, like I said, patient needs to understand that he may have a restricted movement, but of course, FAI has got nothing to do with AVN, but he needs to understand that his range of motion loss is because of FAI rather than the AVN. Uh, there are absolutely no contraindications if we are doing this procedure in patients with leukemias and lymphomas, because they are all off medication, off steroids, and are considered cured. And alcoholic AVN also, I feel it has got a relatively poorer prognosis, probably worse than steroid also. But if the patient is willing to stay off alcohol, I don't think we should deny him this procedure. The biggest advantages of this procedure is that it works very well for grade 2A and 2B hips. I feel that whenever I'm operating on a grade 2A or B hip, I can almost assure the patient of a good result. if they come to me at an earlier stage. Second is that it preserves the natural movement and the function of the hips. And most importantly, it does not burn any bridges for a future total hip replacement. If whenever I have had patients who are like 6 years, 7 years post surgery, and whenever they come for follow up, I always ask them that whether they would like to undergo any other procedure right now for the hip, whether they are comfortable with the hip, and I check their Harris hip score. Surprisingly, the Harris hip score of these patients is in their very high 90s or in the late 80s, which is as good and comparable to a total hip replacement. Plus these patients can undergo all natural activities like sitting and squatting because we preserve their head. So these are a few results basically, and of excellent results of all these patients. Uh, and this with this I come to the end of my first presentation, and I'll take any questions if you have, because I will be now demonstrating uh, uh, basically the technique of this surgery.
Gauresh, I have a question.
Yeah, sir.
Now, most of the patient who comes to us, they have already established by and large grade 3, and it is by accident that we did MRI, you find that 2A or 2B is there on the opposite side. Patient straightforward, only 2A and 2B rarely comes to the hospital. What is your observation?
Sir, it is. I would say that what you are saying is perfectly right. And sometimes the patient has got a grade 3 or a 4 AVN on one side
Yeah.
and a grade 2 AVN on the other side. I give them a very simple example. I say that if a husband and wife are traveling on a highway and both of them have got an accident, the husband has got a large cut and he's bleeding and is in a very bad shape, and the wife is broken a bone and she's okay relatively, she's talking also. Now if there is a layman on the road who's going to choose which patient to send to the by ambulance, the layman is going to choose the husband because he's bleeding. But if there is a doctor, he's going to choose the wife because the husband has got no chance of survival. So if the intelligent patients, they are able to get the message across, and they would get operated for a grade 2 hip with me, and hopefully I'm able to convince them for a total hip replacement on the other side.
How many
That's
patients?
a good way of triaging.
Yeah, sir.
Gauresh, Palekar. I think wonderful talk. I think your logic, I liked your logic, but that's what I believe. And sometimes we do extend our indications, which is not appropriate. And those are the patients who are not happy. If you extend to grade 3, maybe the change collapse of the head, I think they won't be happy. We know that they're not going to benefit, and no point in trying. I think my logic also, most of the people come with bilateral, majority come bilateral, and one side is advanced, as Dr. Babulka said. The other side we can save. So what I would do, I would do the cell therapy first, osteoblast first, then go for replacement, as you rightly said.
Gauresh, one more question. How many patient of yours where you did a totally replacement on one side and treated by your osteoblast on the other side?
Sir, I would say around I must have operated on one side osteoblast and to other side total hip replacement, around 25 plus patients. And whenever they come for follow-up, I always make a point of comparing their Harris hip score. They are invariably, sir, they are more happy on the
With the
natural
cell
side.
therapy.
The reason is very simple, because they say that they have to be more careful in their mind with the artificial hip, while on the non-artificial or the normal hip, they feel that they can do anything. So I think that is the difference. And when you check the Harris hip score, sir, surprisingly, like I said, excellently done total hip replacement. I'm saying an excellent. So a perfectly done total hip replacement will have a Harris hip score of 90, 85 to 90, sir. because they cannot squat, they cannot tie their laces.
Yeah.
Some of them have to use the railing while climbing up the stairs. So it is very instructive. So when we are comparing a Harris hip score of a biologically preserved hip versus a total hip replacement, it is an identical thing. The only thing that I am now looking forward to is how these patients behave, say, 10 years from now. Whether the preserved hip remains preserved for 10 years, 20 years, that is the very instructive thing it will be.
Okay.
Yeah, I think that's a great talk. I think we are overrunning the time now. It's a 9:12. We're supposed to complete at 9:30. So you can quickly run over your video. That would be nice.
Yeah, I'll just run fast on that. Yeah.
We got two more lectures to come.
So I'll just start very shortly that this I started in around 2008, and first patient was a 19-year-old doctor, a grade 2B lesion with a very large subchondral collapse facing a total hip replacement. In this patient, I use a trapdoor technique, Rosenwerter's trapdoor technique, where I curated out the dead bone. The subchondral fracture was elevated by a TAMP, and calcium sulfate, tricalcium phosphate was used in the subchondral region to support the bone. And for bone growth, I used Osgrowth. They were just introducing their product in 2008. So this is the first X-ray. 2 millimeter more collapse, massive involvement of the head, and basically fated for a total hip replacement at 19 years of age. The immediate post-op X-ray, I was able to elevate the cartilage, and you can see the calcium sulfate cement inside. And this calcium cement was the one which I felt would support the head till the time that the osteoblast can grow and support the head. This is the 15-month post-op X-ray, which is very instructive because it shows that the calcium sulfate and the tricalcium sulfate has resorbed, which is suggestive of a vascularity in that area. So I knew that their head is now completely vascular, and there is a joint space maintained, joint contour maintained, and you had a fairly decent pain relief also at that stage. Now, the patient failed at around 2 years, and he went ahead and got a total hip replacement. Uh, Instructive thing was that I need to make a correct choice of case. So 2A, 2B is the perfect place to do this surgery. Second thing is that it underscored the point that the restoration of vascularity is possible by cultured osteoblasts. Third is that curettage of the dead bone is necessary, and the joint motions, space, and mobility were all maintained till the eventual collapse. Now, surprisingly, this doctor at 19, I did a co-decompression by multiple drills on the opposite side, where he had a grade 2A lesion, and that collapsed at around 1 year. So the cultured osteoblast site lasted more for him. Uh, so I also decided that we require a different approach to the hip rather than anterior approach, because anterior approach was very messy and a very large incision had to be taken. So what are the current principles of implantation surgery? The correct, of course, the first thing is the choice of the case, 2A, 2B or less than 2 millimeter depression of the cartilage. Second is the lateral approach to the hip I've used because it's a very common approach used by us. All of us are very familiar with it, and it's a very less traumatic approach. Third is that co-decompression has to happen into the dead zone of the femur. You need to place your drill very, very perfectly into the dead zone. I use a 8 millimeter drill to access and to remove the dead bone. I curate out as much as dead bone as possible to create space for the osteoblastic cell and to decrease the quantum of the dead bone inside. I am very, very careful about injecting the cells to prevent the spillover. I restrict the weight bearing for nearly around 2 months post surgery, and I concentrate post operatively in maintaining the range of motion of the hip. As soon as the patient is post operatively, he starts exercises very rigorously the same day of the surgery. So First step is basically positioning an X-ray. I'm just going to run over this because the video is there, which is going to happen. Second thing is that whenever I'm putting the guide wire into the, I make sure that it is in the center of the avascular zone, and there is at least a 10 millimeter space from the tip of the guide wire to the center of the head, at least 1 centimeter difference, and from the superior neck to the center of the guide wire. So basically, when you are using a 8 millimeter reamer, what happens is that, okay, with the 8 millimeter reamer, it will take out 4 millimeter bone. So still around 6 mm bone remains to prevent a pathological fracture in this area. Also, you will see that my entry point here is not very inferior to get into the superior lateral area. It is almost at the crest or just below the crest, because this allows me to do early weight bearing. And I've never had a fracture or a pathological fracture in so many cases that I've done. After gaining access to the disease area, what I do is basically then ream it out. This is reamed out, and after reaming the head, you can see, always you see the reamer, that there is a dead bone on the present on the reamer, and this is the dead bone which you can see on the reamer. I'm very slow while reaming to prevent thermal injury. So you can see the differentiation between dead bone and live bone onto the reamer, and the amount of bone that I'm curating out. Okay, there is a large amount of dead bone which actually comes out. Like I said, Rosenwasser is basically introduced the term light bulb, and he started curating the femoral head. And I have basically convinced that it is the one which helps to maintain and get a good result eventually. The curating of the sequestrum is very important, and I do it with multiple angled scoop which I have available to me. This is the curating. And sometimes when you see a bony ridge, which is very hard, bony ridge, and in that case, what I do is I will have to drill again and again that bony ridge till the time that I am able to make a fairly large cavity inside the femoral head to allow the cells to go inside. Otherwise, there will be, if there is inadequate cavity inside the femoral head, then what we are talking about, there will be a large spillover of the cells, and the patient may not benefit as much. The injection is by the inside out technique. And here you can see that there is a plug that I have used to prevent the spillover. I also turn the patient on the other side to prevent spillover. There is very rarely a spillover when I use this technique. So this is Dr. Charulat specifically asked me to do a video demonstration of this thing. And basically now the patient is taken on a fracture table. You make sure that you are going to get a very good AP and a lateral of the hip. A lot of time these patients have got abnormal neck and shaft angles. Like here you can see that there is a retroverted head relatively, so that makes the point a little bit difficult to go into the head. You approximately find out the area of where you are going to enter from in the AP as well as lateral, and this is the area of necrosis of the femoral head in this case. So you have to be very clear about your entry point. Should not be very down here, because that will you'll have to prevent or restrict the weight bearing for a significant amount of time. Now this is where I'm marking the femoral, the various surface marking, that the dip of the trochanter, you can see the superior part of the trochanter. Now I'm feeling the anterior border of the femur there. The posterior border of the femur is felt. And thankfully this is a very thin patient, so this makes it very easy. Now that is where the crest would be. So I've marked the crest also. Okay, so I know where I'm going to take the incision, approximately slightly above and below this line. And right, depending on where I'm going to put the needle or the guide wire, I'm going to mark the incision accordingly. This is the incision. It's like any standard approach, to lateral approach to the hip. And after going through it, I basically isolate the gluteal bursa, make sure that I incise it and suture it back again, because it prevents, post the scar tenderness. It is supposed to prevent. It is our technique that I have used from total hip replacement. So even in a total hip replacement, I would suture the gluteal bursa back again into its proper place to prevent scar tenderness. So that is the dissection of the gluteal bursa. You preserve it by cutting it at the back and reflecting it above. And then finally, identification of the ridge. The Basically, you do not need to elevate the vastus lateralis very much. At the area, I would just take a vertical incision at the ridge and then reflect the vastus lateralis little bit inferiorly to get access to the femoral head, to the lateral part of the shaft. Now, this guide wire has been passed and it is right in the center, as you can see from it is at least 1 centimeter from the neck, so as to prevent any chances of iatrogenic fracture. In the lateral and AP you can see. Now second stage is the drilling. Drilling very slowly, so as to not cause thermal necrosis, and yeah, you will sometimes feel that when your drill is entering into the avascular zone, you will have a feeling that you have to give an increased pressure on the head, on the drill, so whenever you are entering the avascular zone. And a lot of times you find when you enter the avascular zone that there is a very special kind of uh, liquid or a fat with globules of fat, or some sand-like material of dead bone which usually comes out. This is a special toothed curette which I'm using to loosen up the bone in the avascular area so that I can take it out with the other curettes. And I have started now scooping this thing and gradually taking out bone. Here I have used it again in case when I find that there is a ridge of bone which is preventing my access into the femoral head. I will do it in again and again. And here it's there at this drilling is happening at the lower end of the cyst, at the area where there is a vascular and avascular zone, so as to increase uh, the area where the revascularization can happen from. Now this is where how the curette, you can see the amount the curette is able to move inside, indicative of the amount of bone that I have curetted inside. And surprisingly, you can see I can reach through this curette with a very small curette. I can reach the anterolateral zone also, less than 1 centimeter. Now this is I have access to Tata bone basically, and I create a bone plug out of Tata bone. Okay, with the bone plug, I feel that I'm able to do a fairly good uh, spillover. I can prevent that. You can also use bone wax and remove it later. Then I will use a 1.1 mm or 1.5 mm K wire in the direction of wherever this thing is, my needle is going to go. The direction is important because here there is, in the bone plug, there is only a single hole there. So the direction of the K wire is very important. I am now checking that the needle is able to pass through the bone plug. Very easily it is passing, and this allows me to prevent any spillover of cells. Now I am injecting, this is where I am now injecting the bone plug, or I think I have already put in the bone plug now, and I am putting the needle inside now. Yeah, the needle is put inside. You check on the C-arm. You can see the bone plug there. You check on the C-arm whether the needle is gone into the area where you want, and then you tilt the patient on the other side. Yeah, the patient will be tilted, as much as, since the patient is on a fracture table, there is no risk of a fall or anything like that. And now we are injecting the cells. Two sets of cells are injected. Yeah. So I think that concludes the technique for the surgery, basically.